Louie. Janice Louie is the medical director of the San Francisco Department of Public Health Tuberculosis Prevention and Control Program and Clinic. She completed her medical degree at the UC San Diego School of Medicine, an infectious disease fellowship at UC San Francisco, and an MPH from UC Berkeley. She has worked in public health at the state and local level for over 15 years and is also an faculty at the UC San Francisco Division of Infectious Disease. Before switching to tuberculosis, she oversaw influenza surveillance for the state of California and led the 2009 pandemic influenza statewide response. For the past 4 years, she has been overseeing patient care and teaching at the FFCPH Tuberculosis Clinic. Will everyone please welcome Dr. Janice Louie?
Hi, this is Dr. Louie. Can everybody hear me okay? Yes, great. Okay, wonderful. So I'm calling in from San Francisco. If there's some background noise, it's because I'm also working on coronavirus. I'm sorry. I'm going to try and keep the door closed if I can. So I've been tasked over the next hour with providing an overview of a complex topic, which is TB in the elderly. And this is an important topic for us in San Francisco. As our population ages, we have come to understand that this is a population we need to pay more attention to and do better with if we're ever going to reach the goal of TB elimination. For us, this is the reservoir from which our active cases emerge. So over the next hour, I'm going to present to you, let me see if I can move these slides. Hang on. Yeah, there we go, sorry. A case, why this is an important topic, review of the literature that exists, a comparison to San Francisco data, and then some conclusions and discussion. So we're going to start with the case, and this is very typical for us. This is a 91-year-old male who is originally from China, who presented to his primary care person with 3 months of cough worse than baseline, weakness, dizziness, and weight loss of 20 pounds over 6 months. His cough was productive but not bloody. He had no fever, chills, night sweats, anorexia, chest pain, or shortness of breath. His comorbid illnesses were typical for a 90-year-old and included atrial fibrillation on warfarin, COPD, chronic kidney disease with a creatinine clearance of 35, gout on allopurinol and colchicine, dementia which was not formally diagnosed. He was significantly hearing impaired and had a history of non-adherence with MD visits, medications, and laboratory monitoring for his INR when on warfarin. He also had a history of LTBI that was treated upon entry into the U.S. in 1996, for which he did not complete treatment. He was treated by us with INH but never finished. He was a prior smoker, had no alcohol history, was a retired computer engineer. On presentation to us, he was very articulate. He lived alone with brothers in nearby apartments. His main daily activities were reading and watching TV, visiting with family, and going out for meals. And he did drive on his own at age 91 to the grocery store and post office. And his main language was Cantonese. Okay, so this is the x-ray that he showed to his PCP, or that the PCP ordered and got, and the interpretation was bilateral upper lobe nodules with a large left upper lobe nodular appearing mass. So a CT was obtained, which is shown here, and shows again the large left upper lobe mass and pulmonary nodules bilaterally in the upper lobes. There's also, some train tracking down here in the right lower lobe, which was consistent with bronchiectasis. So the primary care practitioner referred for a CT-guided fine needle aspirate to rule out malignancy. The resulting pathology showed necrotizing granulomas and no evidence of cancer. The specimen was not sent for culture. I'm sure that sounds familiar to a lot of people on this line. His IRA was negative, and so they appropriately collected sputum, which was found to be numerous AFB smear positive and NAT positive, but with no rifampin resistance. So he was referred to our TB clinic in San Francisco, and we initiated 4 anti-TB drugs, including INH, rifabutin because he was on concurrent warfarin, ethambutol at 18.4 mg per kg, and pyrazinamide. We had a long discussion with the patient and his family in his native language, and he expressed understanding and agreement to home isolation. We also talked to his PCP to inform him that he was starting on TB meds and that he needed to follow his INR very closely. So at dose count 23, the patient returned complaining of new dizziness and black diarrhea. His hematocrit was 20 with an INR that was not calculated but a PT that was over 100 seconds. He was hospitalized and received IV fluids and was stabilized, and it was presumed that he had a GI bleed, presumably secondary to being non-adherent with both Coumadin dosing and PCP visits to monitor his INR. He refused endoscopy while in-house. We requested an ophthalmology exam, which showed significant cataracts on the left. The formal ophthalmology report also noted that the patient had difficulty following instructions. While in-house, we got an EKG which showed AFib, which we knew that he had, with a calculated QTc of 464. He was rechallenged with the same regimen, INH, rifabutin, ethambutol, and pyrazinamide. So after reinitiation of those meds, the patient complained of poor appetite and nausea. His liver function test showed AST and ALT into the 800s and a T-billy of 2.3. So TB meds were held. And after a gradual resolution of his transaminitis, he was slowly rechallenged again one by one, with again a subsequent rise in his LFTs. An abdominal ultrasound was ordered which showed a fatty liver. His Hep A, B, and C serologies were negative, and he was also known to be HIV negative. So he was eventually stabilized on a liver-sparing regimen of rifabutin, ethambutol, and levofloxacin, 750 milligrams a day, with his LFTs remaining within normal ranges. He was discharged after 14 days to home, with instructions to the patient and the family for him to remain in isolation until smear negative times 3. Okay, so as we got to know the patient better, as we all get to know our patients better with daily DOT visits, it became apparent that he was not as self-sufficient as originally thought. The patient was usually home alone at DOT visits, and even though he had a health worker come daily to visit him at the same time every day, he often seemed very confused about the reason for the visit and did not recognize the healthcare worker. The healthcare worker began to call the patient ahead of time to say he would be there in 15 minutes, but would arrive to find that the patient was driving away in a car. TB staff requested a meeting with the patient and his family to discuss the importance of the need for isolation, treatment compliance, and the associated public health risk if he kept leaving the home. We gave him 2 specimen cups for sputum, and we got 2 back with sputum and 1 with urine. So we then requested another family conference to discuss our concerns that the patient was unable to care for self and possibly had dementia, which required a more formal diagnosis or evaluation with his primary care provider. We discussed that if he could not stay in isolation, he would need probably hospitalization and maybe long-term care. We also had a family discussion about imposing a possible legal order if he could not stay in his home, and that if he was found left alone frequently and our concerns with his being unable to care for himself, we might need to call Adult Protective Services. So after this discussion, the family did take the patient's car keys away, but he became very angry at the TB clinic staff, and as a result, the family gave the keys back to him, and so he continued to drive. That's just kind of a little side anecdote there. So at day 45, the health worker noted during his DOT visit that he was scratching and observed a possible rash on his neck. He was evaluated by an MD in our clinic and denied any itchiness, although his exam showed visible erythematous and excoriated rash on his arms and his neck. His meds were held, and his LFTs were normal. He was rechallenged with rifabutin, followed by levofloxacin with daily cetirizine, but he then developed a faint rash on his arms, so the meds were held again. So then we borrowed a protocol that we have from Heartland, where we rechallenged again with a pre-dose cocktail of prednisone 20 milligrams, Benadryl 25 milligrams, followed 30 minutes later by the rifabutin at a dose of 150, but within 15 minutes he developed hives on both arms. So the rifabutin was stopped. We again told the PCP we were stopping all rifamycins, and the patient was started on linezolid 600 milligrams daily. So his current regimen at this point is EMB, levofloxacin, and linezolid. So at 2-month visit, the patient stated, "I'm okay, but I don't feel like eating because I might vomit." He had a weight loss of 4 pounds since starting TB medications. Zofran 4 milligrams was started for nausea, and that was given 30 minutes prior to his TB medications. At his 2-month visit, he was unable to complete the in-clinic visual acuity exam, the Snellen and the Ishihara, presumably due to his dementia and his hearing deficit. He was unable to follow the instructions. So we referred him to ophthalmology for monthly screenings. His 2-month X-ray reassuringly showed some improvement in the left upper lobe consolidation and other areas of upper lobe nodularity, and you can see now that he's developing a cavity as this lesion is evolving. His microbiology at this point was smear negative ×3, so isolation was DC'd. His CMP was stable. His LFTs were normal. His CBC showed platelets of 130,000. At baseline, at the start of treatment, they were 150,000. So his current regimen right now is levo, EMB, and linezolid. So here's the chest CT that's around 2.5 months. And the radiologist read it as a decrease in the size of the left upper lobe mass and the associated areas of consolidation, as well as the bilateral upper lobe nodules. However, there were noted some new patchy areas of nodules down here in the right lower lobe. These findings are consistent with ongoing infection per the radiology report. So we looked at his CT, but we chose not to rock the boat and continue his current treatment while awaiting further microbiology results. And reassuringly, at 3 months, he had a DST that was pan-susceptible. He had a PSQ that showed no mutations. He culture converted at 6 weeks, and at this time he had 2 cultures growing at NTM that was awaiting further identification. So we chose to continue with the current regimen of levo, linezolid, and EMB. So at 4 months, the patient said he was doing fine, but on exam he had shallow lacerations of his right leg, and upon questioning, his family reported he had fallen in the bathroom. He was alert and oriented ×1, and he was unable to bear weight in order to stand and get on our scale. His right knee and foot were slightly swollen with some tenderness. His gross neurologic exam was unchanged, but it was challenging to do a more specific exam because the patient could not follow instructions. For example, we could not perform a good sensory exam to see if he was developing any peripheral neuropathy, and he was unable to follow instructions to assess his motor strength. A plain film of his leg was negative. The health worker reported that the patient was mostly bedbound at daily visits, and he had not observed that the patient was getting up or walking around the apartment. Zofran was stopped due to concerns of worsening mental status. His monthly LFTs were normal, and the CBC showed platelets of 115K, but was otherwise normal. And the current regimen was levo, linezolid at 300. We chose to decrease it after receiving 600 milligrams a day for 2 months, and EMB. At 6 months, the patient came in, and the brother reported that he was telling his family he was having difficulty watching TV. He was alert and oriented ×2, but had a very flat affect. He was unable to comply with the Snellen and Ishihara exam in clinic. We held meds and sent him for an urgent ophthalmology exam because we were worried about both EMB-associated optic neuropathy as well as effects that the levofloxacin might be having. On ophthalmology exam, the report stated the patient was unable to follow instructions and focus on a single point, which made the exam difficult. The report noted that there was no clear change from baseline and concluded that, quote-unquote, the visual acuity deficit does not correlate with the exam. So we then obtained a head CT to rule out an intracranial bleed, which showed multiple areas with small vessel ischemic disease. There was focal encephalomalacia, but it was unclear if those were acute versus chronic. So the patient was restarted on levo, linezolid, and EMB. The linezolid is still at 300 milligrams. So here is his 6-month x-ray. So he is showing still a little more improvement of the left upper lobe mass and even further decrease of the associated nodules in the bilateral upper lobes. So that was reassuring. And at 7 months, he had no complaints. He was now bedbound with a stable appetite and weight. On exam, he was alert and oriented ×1. He had some cogwheeling of the right arm and a slight new contracture of the right lower leg. His LFTs were stable. His CBC showed platelets of 90,000. The family expressed concern to us that TB treatment was making this patient worse, and they were unwilling to bring him in for a chest CT. His current regimen remained levo, linezolid at 300, and EMB. So here is his microbiology summary. He started with numerous smear-positive sputum that all grew MTB that ended up being pan-susceptible, including by pyrosequencing. He grew an NTM that turned out to be M. avium, collected at day 21. He culture converted at day 42, and then began to grow M. abscessus, which we presume to account for the new right lower lobe nodularity that we observed on his chest CT. The patient ultimately had 10 cultures positive for M. abscessus. And as you can see below, it was susceptible to aminoglycosides and macrolides, but resistant to cephalosporins. We chose not to treat this patient for M. abscessus, knowing this would require prolonged hospitalization in this 90-year-old, and from a pulmonary standpoint, he actually was doing quite well. So now I'm going to step back a little bit and look at the problem from a larger picture, but keeping this patient in perspective. So the worldwide population is aging, and by 2030, estimates are that 20% of the U.S. population will be over 65 years. Globally, young adults aged 25 to 44 account for most TB cases, but this is skewed by HIV in Africa, sub-Saharan Africa. However, in Europe, the U.S., Asia, and South and Central America, the elderly have higher or increasing TB incidence rates. These graphs over here are from the WHO Global TB Disease Report in 2019. And what they show in the upper graph is that in several African countries in sub-Saharan Africa, there is a high prevalence that is peaking in the ages 35 to 54 years of age. However, in other countries, including in Asia, including Vietnam, China, Thailand, and the Philippines, and some African countries, prevalence is increasing with age. So likewise in the United States, even though overall our incidence is decreasing, TB incidence has remained highest in the elderly over 65 years. You can see here that our current TB rate in the elderly is around 7 per 100,000, which is much higher than our national incidence of around 2.3 per 100,000. So despite the elderly having the highest incidence rate, there have been few studies looking specifically at this population. There has, however, been a lot of speculation. So most of the literature and focus of research, as everybody knows, has always been on high profile and kind of sexy populations like HIV and MDR, and most of this data is from developing countries. But there is a lack of systematic reviews in the elderly, although there are many opinion articles on how to manage TB in the elderly. And even as far back as the 70s, there has been speculation that TB in the elderly is a different disease. It presents differently, similar to what we might see in a pediatric or immunocompromised population. So I'm going to review the few evidence-based publications I could find. There may be more out there, but this is what I could come up with. So these are all retrospective cohort studies, and the first is out of Korea with a small number of 470. Note that in the methods that standard for drug therapy was used, but it was all self-administered. The outcomes are similar to what we see in the US with measurement by radiographic improvement and culture. So the conclusions of this study are not surprising in that the elderly are more likely to have comorbid illness, they are more likely to have a positive culture and less likely to have a cavity, and there is no difference in adverse events or mortality. However, the limitations obviously are that it's hard to measure these outcomes when all of your TB drug therapy is self-administered and you don't really know the true adherence rate. So here's another larger study out of Nigeria. This was 1,670 patients comparing under to over 60 years of age. Again, patients were treated with a 4-drug regimen using modified DOT, which is when a family or community member administers the drug in the patient's home. And this has been shown to be an effective approach, actually. However, the outcomes in this study were very different from what we use as our standard of care. They used only smear positivity and did not look at culture conversion or radiographic improvement. This is actually the standard of care in many parts of the world. So their conclusions were that in the elderly, they are less likely to be smear positive. They have a trend toward more likely to default because perhaps the author speculated more elderly live in rural areas. And there was a trend toward all-cause mortality. Not only is this hard to interpret relative to our practices in the U.S. because of the outcome of smear positivity only, but this population has a high prevalence of HIV, and so it's difficult to consider these findings relevant, at least to ours in San Francisco. So there's another large study out of India. We're getting larger as far as number. Again, treatment was with 4 drugs, but again was self-administered, so no DOT here, and outcomes also measured by smear positivity only. And again, the findings were that the elderly were more likely to be smear positive, more likely to report adverse events. So this is the first we've seen this. More likely to default and more likely to have all-cause mortality. So same issues with this not having DOT administered therapy and using only smear positivity as an outcome. So in the U.S., let's move closer to home. There have been a couple of U.S.-based studies that I could find. And this is a big macro look using RVCT data, which was conducted over 13 years ago, and is more or less a big picture. So in this study, 250,000 patients. So again, this is RVCT data, the data that we all report to CDC. The elderly were less likely to have a positive TST. They were less likely to have cavitary disease, so this is becoming a common theme, but more likely to die due to all causes during therapy. And again, that's not surprising given the age ranges in this study. So last year, Mas and Narita's group published a very nice study, which was the first to do a detailed look at U.S. patients in older age groups. So this study was out of King County, Washington, which has a population of 2.2 million and an incidence rate of about 7 per 100,000. Moss's group looked at pulmonary cases only and excluded MDR in patients who died at diagnosis. And out of an N of 403, he had 111 elderly patients. So what that group found was that, again, not surprisingly, the elderly are more likely to have multiple comorbidities. They're less likely to have a cavity on chest X-ray. And again, they're more likely to have all-cause mortality. So we're beginning to have some similar themes here. His group was also the first to take a more in-depth look at adverse events, and they found that the elderly over 65 were more likely to have treatment interruption due to a TB medication, and the adverse events included liver injury, hypersensitivity, musculoskeletal pain, and GI intolerance, with PCA accounting for about half of adverse events, followed by some rifamycin, INH, and EMB. If you looked at even more extremes of age in the elderly over 75 years, they were more likely to require more than 12 months of treatment and to have multiple and late adverse events. So this was a very well done study. There were some limitations that not all patients over 75 years of age were systematically started on PZA. There was some non-random assignment based on clinician judgment. And there was also interclinician variability on the definition of an adverse event and when to stop a drug depended a lot on individual provider assessment, and cause of death was not reviewed. So I'm going to bring you now right here to San Francisco, where we also have a similar population to Moss's group. So our incidence rate is 13 per 100,000, and in 2019 we had 105 cases. 90% were non-U.S. born, and over 80% have been in the U.S. over 5 years. The most common countries of origin outside of the U.S. are China, the Philippines, and Vietnam. Our median age is 64 years with a range of 7 months and 93 years. This was in 2019. We actually just started a patient on TB treatment last week who was 101 years old. A half are over 65 years of age, and as I try to show in this graph, but I don't know, part of it is missing, the median age of TB cases in San Francisco is increasing over the last decade. So we also have tried to take a look at our elderly and compare to younger populations. So this is preliminary data from 2016 to 2019, recognizing that we are still treating some patients reported in 2019. So out of an N of 426, we've had 186 that were over 65 years of age, or about 44%. Our patients who are older tend to have an Asian predominance, and that is actually similar to the Seattle population. And they're more likely to have medical risk factors, as they are in all the other studies. But I just want to take a little bit of a closer look at this, because not only do they have the known TB risk factors like diabetes and immunosuppression, but they are also, and it's not surprising, also more likely to have chronic lung disease, chronic heart disease, chronic kidney disease, and mental health illness. And while most of these are not necessarily a risk factor for progression to active TB disease, all of these conditions contribute to challenges in management. Most of the mental health illness in patients under 65 years is due to a psychiatric disorder, but in the patients over 65, it's often due to dementia, which we often find is undiagnosed or underdiagnosed, as I showed in the case I presented. Our older patients are less likely to have HIV, alcohol or drug use, or homelessness. So as far as our cases, if you look at those where you've excluded MDR, loss to follow-up, or patients who have died, our elderly are more likely to have disseminated disease, and by that I mean identification of TB in a site. So, for example, pulmonary and one other site, let me put it that way. For those who are culture positive, they're less likely to be IGRA positive. And for our pulmonary cases only, we found no difference in the proportion that were smear positive or gene expert positive, but we did find that they were more likely to be culture positive. And so remember, this has been consistent in the other studies. We found that the time to culture conversion is earlier, so a median of 21 days versus 33 days if you're under 65. And again, like almost all the other studies, much less likely to have cavitary disease on baseline chest X-ray. So, and you know, why, well, let me go on and we'll get back to that. So let's talk a little bit about drug adverse events. So for this analysis, we use the common criteria for adverse events, which is a standardized scale that is mostly used for monitoring drug adverse events in patients on chemotherapy. A score of 2 means there is some adverse event that is not debilitating to the patient and does not prevent the patient from completing normal daily life activities. So for example, rash or itchiness or nausea, dizziness, mild LFT elevation. A common score of 3 is a more severe reaction, and in general means requiring hospitalization or having significant neutropenia with an ANC under 500, or LFT elevation 3 to 5 times the upper limit of normal. So what we found when we looked at our elderly patients compared to younger patients, in that in general, overall, PZA is not well tolerated, and that's not new news to anybody. Across the age spectrum, many patients cannot complete 60 doses of pyrazinamide. But this was significantly higher in our elderly, so the way to read these numbers is that 65% completed 60 doses in the elderly compared to 72% in the younger patients. Over 40% of our elderly, let's see, so right here had an adverse event as defined by the common score of 2 or 3 to our TB drugs compared to about 25% of those under 65. And again, the most common culprit is PZA, with 24% of our elderly not being able to take PZA or having an adverse event, compared to 14% in the younger cases. Likewise, almost 10% of our elderly were unable to take a rifamycin drug, compared to 4% in those who are under 65. And then the rate of adverse events that were more severe were about the same in both age groups. So around 8% of our patients have a fairly severe reaction to one of our TB medications. So this is an even deeper dive, and this is very preliminary. But I wanted to show a slide that gives a sense of how, when we see drug intolerance, we need to resort to alternative drugs, including in our older population. So what we do is a little bit of out of the box as we extrapolate from the drugs recommended in the MDR guidelines. We take into account the burden of disease on X-ray, as well as the known degree of various drugs, and balance that with the adverse events that are possible. So as you see here, fluoroquinolones are our go-to drug. We use them in 20% of all of our patients. 27% of our elderly get a fluoroquinolone compared to 17% in our younger patients. And note the median duration of time, 232 days on a fluoroquinolone. So a lesser number of patients get linezolid, and that's kind of when we really need to, we do it, knowing that it's not very well tolerated on a long-term basis. 5% of our elderly over 65 have received linezolid. 2% of our younger patients. These numbers are very wide and not very meaningful because the numbers are small. 20% or 19% of our elderly get a rifabutin drug, compared to, let's see, 12% of those under 65. And again, the median duration on a rifabutin in our elderly is around 185 days. So approximately half of this is due to adverse events to a rifamycin. For example, we see a lot of rashes, a lot of cytopenias, and a lot of drug-induced liver injury. But the other half is related to the high proportion of comorbid illness in this population, particularly those patients who are on multiple medications for hypertension, or they're on Coumadin for atrial fibrillation. And approximately 7% of our patients can't take any rifamycin, either because they've had a severe drug reaction to rifamycin, or because they're on a drug that is contraindicated. So lately, for example, we see a lot of patients on the newer factor 10 inhibitors for some type of their need to have some type of anticoagulation, or they're on new chemotherapy regimens that are contraindicated to use with the rifamycin. For example, the tyrosine kinase inhibitors that are becoming very popular to use and for certain malignancies that are more indolent. So in those patients, we cannot use a rifamycin at all. So I'm going to move now to a slide on outcomes. So in our elderly, they are more likely to die due to their TB disease. In over 10% of our TB deaths in the elderly, TB was identified as, here we go, as a primary or contributing cause. So this is a big number if you consider in the context of, say, the current coronavirus outbreak, where this is what we are saying is happening in elderly people with coronavirus, yet there's a lot of fear about coronavirus happening right now and protecting our elderly, but we really don't have that kind of same mentality associated with TB. And so I think we need to change that a little bit. For those that do survive, the median duration for treatment for our elderly is 373 days. So it's over a year. It's about 5 months longer than if you are under 65 years of age. So that's quite a bit more resources put into taking care of our older patients. So in conclusion, as our general population in the U.S. ages, TB in the elderly is becoming more common. We see it here. I think we're going to be seeing it nationwide, and we have to address it. In my opinion, TB in the elderly is difficult to recognize and diagnose. First, it's less likely to be part of a cluster or an outbreak, and so therefore less likely to be linked to a contact or a known patient. It's more likely a reactivation, therefore it's more likely sporadically occurring disease, and it can be more difficult to pick up, and it takes a good clinician with good acumen to recognize. Likewise, in the setting of comorbid illness, symptoms can be nonspecific and difficult to recognize. So, for example, Our patient was brought to the attention of TB clinic following weight loss with the workup that led to diagnosis or workup for malignancy. He had fatigue and chronic cough, which could have been attributed to his chronic lung disease, and his dizziness could have been due to his AFib. His dementia was not formally recognized, and that can lead to vague and nonspecific symptoms. And over time, it took us time to realize our patient was unable to verbalize his complaints well or comply with subjective exams. It wasn't apparent on first visit. It took us multiple visits before we realized that this was a concern. He has chronic lung disease, and an NTM infection is common with chronic lung disease and confuse the diagnosis. Our patient had both M. avium and M. abscessus. So he had a negative IGRA. Remember, the other studies showed a lesser likelihood to have a positive TST, and he did not have cavitary disease on his initial chest X-ray, which again has been consistent with prior studies, and this might lend to the idea that these elderly patients cannot mount a very good or robust immune response, and therefore these particular predictors or factors that we use to help diagnose TB may not be available to us in the elderly. Okay, in my opinion, TB in the elderly is more difficult to treat. So there's an increased likelihood, as I reviewed with you, of adverse events and interactions with other medications. And I know I said this, but it's so common with our patients. We see a lot of cytopenias with rifamycins. We often can't use the rifamycins because of other drugs. In the fluoroquinolones, long-term use is associated with some problems like nausea, vomiting, neuropathies, joint pain. We had one patient who had neuropathy up to his thighs and was falling down on the ground in our clinic before we realized it was probably due to a quinolone. INH can cause a lot of CNS effects like insomnia, dizziness, headaches, altered mental status that can be difficult to pick up in the setting of an underlying dementia. So not only is there a significantly longer duration of treatment, again, over a year in our patients who are older, but we also observe the elderly are more likely to die due to TB disease when we do extensive chart review. And notably, these patients are not meeting any of the classic parameters that we're used to using to determine who is likely to have a bad outcome, such as relapse or treatment failure or death. They don't have delayed culture conversion, and our patients, the median time to culture conversion is 21 days, and they don't have a cavity. Only 15% of our patients have a cavity. So just to think about them a little differently, because our elderly in our review goes against the classical thinking of who is at risk for poor outcome during TB treatment, and this just needs to be recognized when managing these patients. So I'm going to end with a slide that everyone puts in all their presentations. This should be recognized because if we recognize it, then we can work on getting more data. We need a better study of TB drugs, including second-line agents, for use in the elderly, including duration of treatment. We have very little data because most of the evidence for current use of second-line drugs is derived from populations in developing countries that are likely much younger and may have a better tolerance for these alternative regimens. We feel in San Francisco we need to better understand how to manage these adverse events like cytopenias with linezolid and rifabutin, how to use quinolones long-term, and especially bedaquiline in patients with underlying heart disease or arrhythmias, whether we can push the QT above the upper limits of normal, or how do we use it when we can't even measure the QT well in patients with atrial fibrillation. We often struggle with this and don't feel we have a very good answer, and many of our patients have underlying heart disease. So similar to the patient I described with regard to our current patients who are still on treatment, I did a quick review before this talk, and right now 17% of our elderly patients are on a fluoroquinolone, 8% are on linezolid, and 15% are on rifabutin. So we are really working off the grid as far as using MDR regimens in an elderly, very vulnerable population. And then my last point is I think we need to have a better understanding, and this is kind of a clarion call, to really understand the associated costs and resources that it takes from both a medical and public health standpoint to take care of these patients well, including the catastrophic cost to family and the support networks when the decision needs to be made about long-term care and other psychosocial issues. So as I described in our case, and I've alluded throughout this presentation, undiagnosed dementia is a significant challenge. When I first presented this case last year, Dr. Starks recommended that we perform dementia screening in all of our patients who are over 65, and we now do a mini-COG followed by a MOCA in all of our patients over 65 years of age. So this particular patient scored 0 out of 3 in his mini-COG exam. And knowing this really helps both our nurses and our health workers in the field when they're challenged with just a patient's not responding, is not making sense to them, is not clear what's happening. Understanding that mini-COG score really helps us to provide some context and better care. And as in this patient, I just want to point out, it's not unusual for us to request multiple family conferences to gently introduce the concept to the family and caregivers that this patient, their beloved elder, may have dementia, which is not going to get better with TB treatment. The diagnosis of TB is often the first sign to a family that the patient can't care for self, and this is often kind of a devastating realization that takes time to present and reassure. There's often a need for multiple family conferences to reset the expectations that treating TB will make everything better, including the patient's mental status. It's often accompanied with a lot of denial and concerns about the financial implications of having a patient needing long-term care. And so we spend a lot of our nursing support time on this particular area. So in conclusion, we need a better understanding of the unique challenges in managing these elderly patients. Screening for dementia can help, as well as understanding the other comorbidities, supporting caregivers, and understanding there are sometimes very complex dynamics when you're treating an elder statesman and a family, working with PCPs to ensure good cross-disciplinary care, getting these patients to end of treatment, and for us, even understanding when is the end of treatment, because we are just working outside of the box as far as the regimens that we're using. And as we get to know these patients, realizing that for 6 or 9 months or more on a daily basis, we may have an opportunity to make a huge difference in their long-term care and quality of life if we kind of, don't ignore anything that comes up and really address these issues, and maybe can provide better support to both the patients and their caregivers and their primary care physicians in making some differences in their quality of life. So I'm going to stop there, and I will rely on Delphina or whoever else is in Texas. I'm in San Francisco to tell me what to do next.
Thank you, Dr. Louie. Thank you, Dr. Louie, for that wonderful presentation. Can everybody hear me online okay? Uh-oh. Can everybody hear me now? Okay. Okay, great. Sorry about that. I had my volume too low. Okay, great. So now, Dr. Louie, we're going to go ahead and address the questions that we received from participants online. I'm just going to bring it up here. So the first question is from Elizabeth Foy. Which FQ do you prefer or use more often in this population? Do you find more or less intolerances in one over the other?
So hi, Elizabeth. We typically use levofloxacin first, and we work closely with our state partners, and I don't know if Pennon's on the line. I think levofloxacin, and maybe Barbara knows as well, has a little bit less of an interaction with the rifamycins. However, we don't have a preference, and so if a patient says they only want to take 1 pill versus 2, we will use moxifloxacin. And it's funny, sometimes if we have a strange adverse event, like we had one cheek who said he had cheek numbness, we will just switch to the other quinolone and it will go away. So a lot of it doesn't make any sense. A lot of it may be psychological on the part of the patient, but we have some very unusual adverse events we hear about with one, and if it's not severe, sometimes we'll say, okay, let's try this different pill. It's a different color, and sometimes it goes away. But in general, we use levofloxacin as our first line.
Okay, and the next question is from Tommy Camden. Was a patient tested by both quantiferin and T-spot?
So we do not have, this is San Francisco where quantiferon started early, so we don't use T-spot, so I don't have any way to compare to how the quantiferon would compare to T-spot in the elderly. Sorry about that.
Okay, and then also somebody is asking if you could share the screening tools with the audience.
Yeah, so I'll tell you how I found these screening tools. I'm an internist, but I'm not a geriatrician, and so pretty much I went to Google like everyone else. There are some very good screening tools recommended by the American Family Practitioners Associations, and one is called, we use the MiniCog, MINI-COG. It's available for free. It's essentially 3 simple questions. We have many patients in different languages. It's available in many languages, and it essentially asks patients to perform a short memory test of 3 words and to draw a clock and put a time on it. That clock is very telling. If you ask a patient to draw a clock and ask them to say, make the time 10:11, we have gotten things back like a picture of a horse, like very strange things. So it's a very good test. And so that is our first test, and if they fail that, they go on to a more expensive exam called a MOCA, which you can also get online, MOCA. And mostly what we do with that information, not only does it help us understand the patient, we can work with the family better, but we think it's very important to share that with the primary care provider in case they feel a dementia workup is indicated, or we just feel it's very important to have kind of cross-disciplinary information exchanged about that when we find it positive in our screening exams.
Okay, another question, why rifabutin and not rifampin?
Yeah, so I see 2 questions related to this. So because the patient was on warfarin, in our practice we typically will use a rifabutin because it may be less hepatic inducing as far as the hepatic enzymes. And so you may not have to adjust the Coumadin as much with rifabutin as you would with rifampin, and that's just our general practice. Should I keep reading the questions?
Yes,
I can see
please.
them too. Yeah, sorry. There's a question from Valerie. As IGRAs are not positive in the elderly due to less robust immune response? That's my theory anyway. Would the same be for TST, or is this different? So I don't know the answer. I would assume that big study from the RVCT data did find that the elderly were less likely to have a positive TST. I can only tell you our practice. In general, we are moving away from TST, one, because we are now moving to electronic medical records, and it's hard to record a TST result in EPIC, but it is easier to record an IGRA result in EPIC. And the other is we get a lot of TSTs from outside places where we are not sure that it was either administered right or it was read right. And so I think this is a very important function that TB nurses are especially skilled at. And I think it's very hard for someone who only does it a couple of times a year or 5 times a year to really produce reliably good TST results. So if we see anything that doesn't look like it's a very large reaction, we will repeat and we'll get an IGRA. And again, we're moving toward that because of our electronic medical record, and it just makes it easy to document and for other providers to see that same result. Let's see, do I do EKG on the elderly on fluoroquinolone? So we do not. It's a thought. It's actually in San Francisco. We don't have our own EKG machine. I actually think that's a problem in many clinics. We're in the process of getting one, but it's going to take us a year or more. So we do not. And I think if we are going to use fluoroquinolone and another QT prolonging agent, we would consider it. So, for example, we are trying to get an IRB together with UCSF for clofazimine, and Barbara and others have been trying to help us with that, as well as UCSF. We would consider it, but right now it's a test that has to be ordered. It means that our patients have to come back in and go to another place and wait in line and get it. And so in our elderly in particular, that's a little bit of an effort. So right now we don't, but we might change that practice when we have our own EKG machine here. Okay, so Chris, hi Chris. CDPH group, we agree, thank you Chris, of using levo over moxie when rifampin is being used due to drug-drug interactions. So thank you. I'm glad to have the backup of our state health department on that one. If the patient is having a lot of diarrhea, what med would you suggest patient is unripe? So this is a hard one. We don't typically see a lot of diarrhea in our regimen. Sometimes it's often transient, and then if it's significant, we will stop and then re-challenge, but that has not been a big problem in our patients, either young or old. And then Chris is asking, right, some providers have a concern for increased risk of C. diff with fluoroquinolone, so same topic here. So Chris Key used to be with us in TB clinic, and I don't recall ever seeing a patient on a fluoroquinolone use with C. diff or having concerns of prolonged diarrhea. I think if we saw it, we would definitely get a C. diff, but we haven't seen it in my 4 years here. Actually, it's very interesting. We have other issues with chronic fluoroquinolone use, like neuropathies and the arthralgias and numbness and nausea and vomiting. So other strange things that you don't see with short-term quinolone use, but with long-term we do. So we don't see a lot of diarrhea or C. diff. For the last question, was the patient referred to a neurologist for further definitive diagnosis of dementia? So he was seen by a neurologist while in the hospital. The neurologist did not have much to offer, frankly, and I think the better place for this is a PCP, especially if it's a geriatrician, because they are actually fairly well-versed in diagnosing dementia, and not that I'm sure there are many treatments for dementia. This patient, if you recall, his head CT showed what looked like encephalomalacia and signs of small vessel ischemic disease. So he probably has been having maybe mini strokes or CVAs or recurrent embolic phenomenon. He does have AFib. He is non-compliant or not adherent with his warfarin. So there are a lot of possibilities for his undiagnosed dementia, but no, we did not refer him. But we did tell his PCP of the finding, and we want to make that a common practice. So I hope I've answered those questions well. I can only suggest what we do here in San Francisco.
All right. Well, thank you so much for your time and a wonderful presentation, Dr. Louie.
You're welcome. It was a pleasure. I was happy to do it.
All right. So,
and folks, I'm happy to share my email if there are more questions that come up later.
okay, great. Thank you, Dr. Louie. Let's see. One more question. Dr. Louie, if you don't mind, what do you anticipate as the length of treatment for the case you presented?
Yeah, so, yeah, he was on EMB, levolinazolid. I think so. I confess that we rely on Gisela Schechter, who is in our clinic and has much more experience with going off the grid as far as using alternative regimens. So we try to balance treatment, radiographic improvement, and adverse events, and age of patient, and how hard it is to come in. And I would anticipate he did not, I'd have to go back, he did not get rifamycin for 60 doses, but probably if his x-ray continued to do well, we would probably try for at least a year, as long as he remained with negative cultures. There could be a lot of debate on that, and that's what we're struggling with, is balancing how long do we treat. We're basing it a lot more now just on culture conversion, radiographic improvement, weight gain, improvement in symptoms, and then kind of hoping for the best, because in our experience, when we try to go for longer, we start to run into a lot of adverse events and also uncover other things that, you know, maybe we didn't need to if we didn't continue to prod and poke our patients every month. That's a great question. That's like the gist of why we're trying to do more with these patients, to understand what is our appropriate length of treatment for these different regimens and balance that with adverse events.
Wonderful. Thank you once again, Dr. Louie. If you have any further, if you have any
You're
further
welcome.
questions for Dr. Louie, I might be more than happy to send them her way.
Yes, I don't know if there's, my email is easy. It's janice.louie@sfdph.org. And I don't consider myself an expert on this, but I'm happy to share what we do in San Francisco.
Okay. Thank you. We'll go ahead and continue then. If there aren't any more